Okay, let's get into it. Today, we're diving deep into a really high-stakes situation.
A very high stakes one.
We're looking at the Australian Medical Council clinical examination, specifically the psychiatric medicine part for international medical graduates, or IMGs.
Right. And our mission here is to understand the structure that's used to guarantee competence, and patient safety when time is the one thing you don't have.
And the pressure is it's intense. Your sources highlight that the clock, that strict 8-minute assessment, is the #1 reason people fail.
It is. And psychiatry is so unique because you're not assessing a tangible physical sign. It's all about the art of communication, of observation.
And proving you're safe that quickly seems like the ultimate challenge.
It is. It really is.
Which brings me to the scoring. It feels almost impossibly quick. The source is clear that everything hinges entirely on the global rating. You need a 4 or above.
Mm-hmm.
So a candidate can, take a perfect history, check all the boxes, but still fail if the examiner just feels they missed a safety cue or didn't build rapport.
It is rigorous, yeah, but it's completely intentional. If you connect it back to the graduate outcomes, the global rating is basically answering one critical question.
And that is
this candidate safe to be left alone with this patient? It's a mechanism that forces examiners to put safety and communication above everything else.
So how on earth do candidates manage it all? Rapport, history, risk, management, all in that tiny time frame. There must be some kind of scaffolding they use.
Absolutely. The framework is the safety net. It's what the sources call the 2+6 temporal structure.
2+6. Okay, break that down.
Well, the first minute is often called the golden minute. That's for your intro, building rapport, and just actively observing, early mental state exam components.
Like appearance, behavior, that kind of thing.
Exactly. But the source warns that by about 45 to 60 seconds, the candidate must take control and start guiding the conversation.
Or the patient's anxiety will just eat up the entire 8 minutes.
You got it. And that structure leads right into the most critical part.
Minutes 4 to 5. The safety check.
The mandatory non-negotiable safety check. Correct. Omitting a thorough risk assessment is an automatic fail.
Wow.
Yeah, and candidates have to use really direct questioning. They follow the TASAR model for suicide risk.
TASAR, so that's thoughts, attempts.
Which is noted as the strongest predictor of future attempts.
Right.
A specific plan, and then risk and protective factors.
And we can't forget about homicide risk. The sources flag that duty to warn if a patient makes a specific threat about an identifiable person.
Yeah.
That overrides confidentiality.
100%. So once that immediate safety piece is done, you still have to figure out what's causing the problem. This is where the diagnostic sieve comes in.
It's a hierarchy.
It's a hierarchy, exactly. You have to rule out organic or medical causes and substance use first. Always first.
Before you even get to psychosis, mood, anxiety.
Right, because that order prevents you from missing something acutely treatable, like a delirium.
That's a huge lesson in prioritizing the urgent. And shifting to management, the sources had some great advice for navigating, difficult dynamics.
Oh, yeah.
Let's take a manic patient, one who is expansive and trying to crack jokes. The advice is to use graded assertiveness.
Which means you have to interrupt them, but safely. You maintain professional boundaries without sort of getting sucked into their grandiose stories.
And then for the drug-seeking scenario, which I imagine comes up a lot.
It does. The strategy is defined as saying no with empathy. You offer non-opioid options, but you absolutely have to mention checking the prescription monitoring systems.
Like SafeScript in Australia, it shows you're doing your due diligence.
Exactly. Professionalism.
We also see this essential focus on cultural safety woven into this whole efficiency structure.
We do. The sources highlight a communication style called yarning.
Which is that conversational storytelling approach.
It is. And a key piece of advice is not to rush silence, which in certain cultural dynamics can be seen as really disrespectful.
So all of these structural elements, the 2+6 timeline, the TASAR model, the hierarchy, they all funnel down to one single goal.
Clinical safety under pressure. The framework becomes the discipline scaffold when the clinical stuff just gets overwhelming.
It's fascinating how much high-level competence they demand in so little time.
It really is. So what does this all mean for you listening at home? These medical sources detail the 4-step capacity test, which is used to see if a patient can consent to treatment.
Right. Can they understand, retain, weigh, and communicate their decision?
It's a rigorous, mandatory framework. So perhaps we can apply that same 4-step structure, understand, retain, weigh, communicate to our own high-stakes decisions, outside of medicine.
It's a powerful mental checklist for life.